box. Okay. The physical exam is not overly concerning for there being extension into the hypopharynx,
Okay.
but the CT scan indicates it. So that's why I'm interested to see our scan.
Okay.
It looks like, oh, she's pulling it up. Yeah, it's in life image still. It looks like some of the swallowing tube there might be a little bit of a wraparound effect going
Okay.
on here. Okay. All right, so what do we know about this cancer? Well, we stage all head and neck cancers. And in head and neck cancer, staging is done by the tumor size, the lymph node involvement, and whether or not it's gone anywhere else. Okay, so T and M. The fact that your right vocal cord is paralyzed, okay, and we see what's called paraglottic extension. And I'm writing this down because when you go and look at stuff on the internet, these are the things that might pop up on your Google search.
Sure.
These two findings make you T3.
Okay.
Okay. Now to jump to it, that's in the glottis. T1 is on one vocal cord. T2 is two subsites, so
Okay.
vocal cord and above. And then T3 is paralysis and
Okay.
deeper extension. T4 is busting out of the larynx. And I honestly don't see that on your CT scan.
Okay.
So I don't know what criteria they use to push you out to T4, other than maybe this extension, but quite honestly, it was subtle at the time of that. So I would put you T3. Let's just because we trust those guys, we'll say possible early T4, okay? You have a single lymph node on the right upper side.
Okay.
There's an abnormal lymph node on your CT. I don't really feel it in your neck. It's small,
Okay.
about the size of the shooter marble,
Okay.
but it's abnormal shape, and
Okay.
so we'll call it a positive.
Okay.
It's 100% expected with this tumor. Supraglottic cancers metastasize early.
Okay.
So no matter what we do for treatment, we're going to recommend treating the lymph nodes, whether it's surgically removing them or radiating them. Either way, we're going to remove them. Do something with them.
Okay.
And then I didn't see any disease in your CT scan from your lungs. Did Jay tell you anything about
Yeah,
that?
he said didn't see
Okay.
anything.
So
I said it
has-
was clear.
Good. Okay, so no metastases. So advanced local disease with small amount of lymph nodes, low volume lymph nodes, no metastasis. But this makes you stage 4. So if you want your friends to feel sad for you, you tell them you have stage 4 cancer.
Yes.
But honestly, it's not how we function here.
Right.
We look at what's involved and what can we do about it.
Good.
So T and M is way more important to us than stage 4. So
Okay.
if you Google, you're going to see yourself as stage 4. But in head and neck cancer, stage 4 can be this, advanced disease. It could be a couple lymph nodes. That makes stage 4. It
Gotcha.
could be disease all over your body,
Yeah.
stage 4. So those are very different clinical scenarios,
Yeah.
right? So stage 4 doesn't tell us what we need to know.
Okay.
T and M tells us what we need to know.
Excellent. Yeah.
Make sense?
Yes. Makes
Okay.
sense.
All right, so what's the treatment for this? Well, in larynx cancer, in general, we have an option that involves surgery, plus or minus radiation. And we have an option that's non-surgical, which is going to be chemo radiation. Okay, no surgery involved.
Okay.
So we call this organ preservation, and sometimes in this case, like in your case, this is an organ removal,
Yeah.
right?
They gave me the trifecta.
Right.
They-
Yeah, they are just all over that. So,
Yeah.
okay, so how do we decide? Well, in stage 4 cancers, the chances for chemoradiation working is somewhere in the 65 to 75 percentile. That's not great,
No.
but it isn't 0.
No. Right.
In the surgery side with stage 4 cancers, we jump up a little bit more into this range
Okay.
with that. But what's super interesting about voice box cancers is that those patients that fail this often can be salvaged with this later,
Okay.
which is like some cancers. Some cancers, if you fail it, we can't salvage it. Once you recur, you die. That kind of thing.
Yeah.
But not in voice box cancer.
Okay.
Voice box cancer does have the ability to, if you recur, to then take the voice box.
Okay.
So a lot of times we use function as a guiding principle to which treatment we should start with.
Okay.
And that includes your swallowing and your voice,
Okay.
right? And I guess breathing too.
Yeah.
So, because that's what this organ does.
Mm-hmm.
So if you came to me and you couldn't swallow it all and you had a peg, you already had a feeding tube,
Mm-hmm.
and you had a trach,
Mm-hmm.
then I say, why are we trying to save this voice box? It's
Yeah.
already been destroyed.
Right.
Take it out.
Okay.
Do laryngectomy.
Okay.
But the fact that you swallow, breathe, and talk relatively well,
Yeah.
I'm hesitant to say right now we have to take this voice box out.
That's good.
Yeah, it's an interesting idea, and
Yeah.
it sounds like if they did presented you with that option, they put it on the this is not a good idea option. You should have surgery option, and didn't give you an opportunity to really contemplate what that.
They didn't explain it like
No.
this, and they basically said this is your only option.
Yeah.
Surgery followed by chemo and
Yeah,
radiation.
it's a great option.
Yeah.
And quite honestly, just meeting you in the last 15
Yeah.
minutes, I would tell you you're going to do great.
Yeah.
Because you're young, you're healthy, you're motivated, you got
I'm
great
not sure about
support.
the young part.
Yeah, yeah.
You know?
But you could do it. Laryngectomy is doable.
Yeah.
And in the right hands with the right speech pathology group, we're going to get you back to speaking. We're going to get
Yeah.
you back to talking. So, I mean, that is, by all means, if that's what we circle back to, because there's something I didn't see before,
Yeah, yeah.
or if my chemo radiation guys say now we can't do it,
Yeah.
then fine. We'll talk about it, and
Right.
Moreno's team can do it, or I can do it, or whatever.
Yeah. Okay.
But I think because you have such good pre-treatment function,
Mm-hmm.
it might be a good case to think outside the box a little bit
Yeah.
and think about whether or not we could consider this and salvage this into that,
That would be-
into a voice box saving scenario.
Yeah.
Kick the can down the road a little bit
Yeah.
about
They pretty
taking out
much
the
gave me
voice
a
box.
gloom and doom
Yeah.
picture of
Yeah.
just chemo and radiation.
Yeah.
They said if you just do that, it could spread all over the place, and you'd be like a gone pecan.
Yeah, that's an interesting thing. I would have said you could do all that, we don't cure it, and we end up having to go to surgery.
Yeah. They didn't even list that as an option. It
Yeah,
was more like,
so it's super
yeah.
interesting that they chose to say it'll go all over the place.
Yeah, well, I don't know if they put
Yeah.
it in those words, but it would be almost
Yeah.
like we'd have to do it anyway, and it could be hopeless at that point.
Yeah, well, that's the case with any treatment.
Oh, sure,
right?
sure.
The numbers are not 100%.
Yeah,
And a cancer's born the way it's going to be born.
yeah,
And if this is one of those cancers that wants to spread, we could do everything
Yeah.
and still end up with a lung nodule.
yeah,
And while we know if we can control the disease here, we have our best chance for controlling the disease forever.
sure.
Recurrence definitely sets you up for problems down the line.
Sure.
But I don't know if it's quite as gloom and doom as the way they're presenting
yeah.
it.
Yeah, it was pretty much this is it.
Yeah, yeah. Well, and this is why you get second opinions.
Yeah.
They've known you a lot longer than I have, right?
Not
so I
really.
want, yeah,
No, they really
not
haven't.
really.
Not really.
Interesting. The hell out of that. So that makes me think that I just need to make sure I'm not missing something that I don't already know
Yeah.
about.
Absolutely.
Let me run this scan.
Yeah, you can see him today.
Okay, great, perfect. I think that would be great. What about Greg tomorrow or
There's to
Thursday?
see patients on, I could ask Molly if they.
Well, we
can
could
come out
also
Thursday.
go downtown. Could you maybe call Bill and see if they can find out if somebody could see him
Yeah.
downtown?
Yeah,
You guys could stay a night or two, right?
Yeah, we'll just stay at the
Okay.
same hotel.
Yeah, and see if we can get a radiation consult, because I think it matters. You don't want to cancel your surgery date. You have
Yeah.
a great
No,
surgery
not
date.
yet.
Yeah, so, yeah, that would be great. So let's, we got a med-onc appointment for this afternoon. We'll see what we
Okay.
can do about getting the radiation team. So if we don't mind
Great.
making a
Okay.
quick couple
Okay.
phone
Okay.
calls. Okay, so I don't know, how much do you know about CAT scanning? Nothing?
Plain field radiology. I was a chiropractor before.
There you go, okay.
So,
So-
this is out of my league.
Okay, so CAT scans are like bread slices. So when you lay on the table your loaf of bread, we're gonna cut your head off, we're gonna look at that slice.
Mhm.
Then we're gonna cut the next slice, the next slice. We're gonna look at that slice in little pieces.
Okay.
Right is on the left, left is on the right, so we're looking at a mirror. Bone is white, gray is tissue, black is air.
Okay.
All right, we gave you contrast dye. So they put an IV in you, they got contrast, that makes the blood vessels turn white
Okay.
because it's iodine. So this is a slice through your brain. You can see your sinuses here, your skull, brain is present. Can't
Okay.
tell about function, but
Just
it's
just thought I was in your head, you know.
doing fine, present. There we go. All right, so we'll roll down a little bit here. Now we're seeing things we recognize. Here's your eyeballs, top of your ears. We're gonna roll down a little bit more. Now you can see your nose, your sinuses. These are your cheekbones. Those are your ear canals. As we get a little bit further down, we start seeing the top of the jaw. Here's your
Okay.
upper jaw, and then here's your lower jaw. You've got some dental work, so you can see the scatter from the dental work. As we come out from below the dental work, we now can see your jaw and your tongue.
Okay.
All right, as we roll down here, we're gonna start seeing the stuff that it matters to us most.
Right.
This is a cross-section of that epiglottis.
Okay.
It's attached to the back of the tongue and it becomes the top part of your voice box.
Gotcha.
Before we jump out of that though, there's that abnormal lymph node.
Okay.
So this is the jugular vein right here and
Okay.
here. That's the, carotid artery and jugular vein. And there's this little lymph node, it's kind of round with a
Yeah.
little juicy center there.
Yeah, see?
That's an abnormal lymph node.
Okay.
You don't see one on the other side, and we're
Okay.
all about symmetry. So when we see something asymmetric like that, plus we know it's on the right,
Yeah.
so it tells us that's probably a metastasis.
Okay.
So there's that epiglottis. We're going to roll down here. So now we get to the voice box. This is here's the Adam's apple cartilage right here.
Okay.
This is the top bone called the hyoid bone.
Yeah. The only bone that does not articulate with another bone in your body.
Good for you.
Yes.
Yeah, that's right. So this is where we start to see a little bit of abnormal stuff. This is this,
Okay.
okay? And what we don't know is it looks like this wraps around into the piriform sinus right here on the CT scan, but it could also just be folded back on itself. That's why I was
okay.
curious about who did your DL, right?
Yeah.
It's possible that that piriform sinus is indeed involved
Okay.
with the cancer. As we roll down here, this is the left vocal cord, and you can see there's a fat pad and some normal structures here, but here you just see blob.
Oh yeah.
So that is that tumor in the paraglottic space.
Gotcha.
It's what's paralyzing that vocal
Okay.
cord. Because once you have all that in there, that cord can't move.
Okay.
But we get to get a little past the vocal cord. Now we're actually at the vocal cord, the V, and that looks pretty normal.
Oh wow.
So this is a true supraglottic cancer. It is above the vocal cord. In fact, if we could push that over, we might see a normal vocal cord.
Okay.
It's not normal because of what's happening under
Right,
the surface, but that's a very interesting thing. It's why you breathe fine,
Yeah.
right?
Okay.
Because this is all just kind of soft stuff up at the top. So this is a true supraglottic cancer. T3, again, I'm having a hard time figuring out how they got to T4 based on this. But in general, again, it doesn't really matter. Here's some more of those funny lymph nodes.
Okay.
So I probably upstage you to N2 on just
Okay.
because you have a couple of them in
Okay.
a row.
Okay.
But that's what we've got a month ago.
Okay.
It'll be interesting to see what we get on the new scans
Okay.
tonight. So
Great.
we'll sit with that for now.
Okay.
Okay, so another way to think outside the box that might cross the bridge between this and this
Okay.
is in the correct patients, we have offered chemo for a couple cycles before making the decision about radiation or surgery. When you give chemo doesn't cure this cancer, but it can jumpstart things. It can get this cancer getting better. It can make you feel better. You don't have a lot of symptoms, but it can improve things. And when a tumor responds to chemo, it is more likely going to respond to radiation. But if it has a soft response to chemo, doesn't really do much, then we know radiation probably won't reach the cure.
Okay.
In other words, we fall on the wrong side of those statistics.
Gotcha.
So in some patients, and you may be the right patient,
Mm-hmm.
to try some neoadjuvant chemo, that means chemo before,
Mm-hmm.
and check.
Okay.
And if the tumor responds and you feel better, go into chemoradiation and cross our fingers.
Yeah.
If the tumor doesn't respond, we lose nothing because
Yeah.
we now know it's not an overly radiosensitive tumor.
Okay.
We go to surgery, which is already scheduled.
It's already scheduled.
Right, and it's
Yeah.
the same surgery, with or without the reconstruction. I just have to look at your scans. But the safe bet is to have Dr. Moreno and the reconstruction on board. But there are some patients that we can do it without, and then we get a primary TEP, which is
Okay.
lovely. So again, I'm not going to commit to that till I see your scans a little bit more.
Right.
But that's kind of what I'm thinking is, our tumor board will think about is are you a good candidate to push this non-surgical side and see what we can get out of it? And with the full understanding that we might have to reverse courses and head back into the surgical
Oh,
arm.
that's fine.
But why not, my gut feeling with you is, given that you have such good function starting in, to take all that away, like, I'm not sure that's the right answer right now.
Yeah. I mean, I was questioning, but this is out of my
Oh,
league,
this- Yeah, and this would work.
Yeah.
I guess it's not 100%.
No,
but-
neither one. I mean,
right,
you're talking
neither one.
10%. you
Right,
know?
that's right. It's not 100. It's not guaranteed. The nature of this cancer is none of it's guaranteed.
Mm-hmm.
But which one is most guaranteed? I don't think we know that
Oh,
answer.
But
Um,
if they, what you're saying though is if they do the radiation and chemo, how long will it take for them to know if that tumor is going to respond to it?
Oh, if we went with a non-surgical?
Yeah.
So if we make the decision to go to chemoradiation, then that's what we're doing.
Yeah.
And we go for it all the way through, and then 8 weeks or so after you're finished up, we get our first CAT scan, and hopefully there's no cancer there, and then we just follow that forward.
Okay.
And every 3 months we get scans and whatever else.
Okay.
And if it recurs, most of the time it's going to recur in the first 2 years, so we do tight, close watching for 2 years.
Okay.
And then if we ever see a recurrence coming up, then our next option would be
Is
a
surgery.
surgical
Okay.
option. There is a possibility, if it recurs, that it recurs in a place that surgery is not going to help, like in your lungs or whatever.
Sure.
But that biology is for either arm. It has nothing to do with treatment here. It has to do with the nature of
It
this
could come
cancer.
back anywhere.
You could have your whole
Either
voice
way.
box removed,
It
everything
could
could be
happen.
cruising along, and still get something in your lungs.
Yes.
So if they implied that doing this would prevent that from
I
happening,
kind of got that indication.
that's not true.
Yeah. I'm going to look up on my Healthy VA,
Yeah.
see who did the.
The DL.
Now, what is a DL?
That's where you went to the operating room and did a biopsy.
Doctor,
Sounds
Tolanet.
like the general ENT.
the ENT
Yeah,
is the
yeah.
one that did the
I'll look at
biopsy.
her report. She probably
yeah.
sent me her op report. I'll
Okay,
take a look
good.
at
And
it.
if not, I can forward it to you right from here. I got it.
Yeah.
I got everything downloaded.
Perfect. Yeah, I'm not sure it matters at this
Yeah.
point. I think
Now, I know that Gary he's being a retired chiropractor, he's done a lot of research. He
Maybe too
mentioned
much.
about folks that have done the radiation and the chemo first, and then surgery. They ended up not being able to swallow
Yeah.
or do anything. What
Yeah.
are those chances?
reasonably high,
Yeah.
right? So
Either
it-
way or just with one.
well, with the chemo radiation. So
Okay.
we are taking out the larynx and the surgical option. So
Yeah.
that goes away. In the organ preservation, our goal is to save the organ. But sometimes the treatment we can get rid of the cancer, but the organ itself doesn't survive through the treatment.
Right.
And
right.
then that necrosis or dysfunction occurs, and then we have to go to take the surgery, do this.
So, but I don't know if that, in my mind, it's not answering.
I
Like,
just want to be able to eat.
yeah, to be able to eat and swallow.
Yeah.
If you go the radiation chemo part, is that going to cancel out down the road being able to eat and drink? I mean, eat and swallow if you have to have the surgery at a later date.
Oh, great question.
Yeah.
So the answer is I can't guarantee 2 years after getting cured from your cancer with chemoradiation that your swallowing won't be adversely affected. You may start, the long-term radiation side effects may result in inability to swallow. And if that starts to decline, some patients choose to go ahead and remove the larynx so that they can swallow better.
Okay.
Some patients say, fine, I'll G-tube it and I'll keep my voice box, right?
Yeah.
But because there's no cancer, we can discuss that
Yeah,
as it happens.
absolutely.
Doing the laryngopharyngectomy, taking the voice box out and repairing the pharynx, is harder after radiation.
Yeah.
It's harder.
Yeah.
So there's more risks, there's more complications, whatever. Whether we're taking it out for dysfunction or taking it out for cancer because he recurred.
Okay.
But you get to a place like Arkansas or MD Anderson, 50% of what we operate on is in radiation patients.
Mm-hmm.
So, you know, that happens. So I guess I look at it as, are we going to give it a shot to save, or do you want to just not? You know, and I'm fine either way. I mean, Mauricio do a great job. If you're like, you know what, I don't want to go to surgery up there, I want to do it at Anderson, I'll do it for you. Like, I mean, whatever you guys decide,
Yeah.
we just want to make sure you have all the options and all the answers that you can think of. None of them are going to sound great.
No.
Nobody's going to be like, well, that's fantastic.
That's-
Let's sign up for that.
That's a peach.
Nobody's going to do that. You know, everybody's going, none of what we're at. I mean, it just sucks that you have a cancer where you have it
Yeah.
and it's as advanced as it is. I'm just trying to contemplate the possibility of at least giving you a chance to save that voice box,
Yeah.
keep it where it is, keep practicing, you know, preaching for even a little bit longer,
Yeah.
you know, before we have to take it out. And I hate to say it like that, but maybe we'd have to. Who knows?
Yeah,
We-
I mean that's
yeah.
a possibility. I'm
Yeah.
trying to find where I sent. I think I sent your mom.
That's okay. We'll find it. I'm not too worried about
Yeah,
it.
it's all in the regular.
It's just
text
that you neither here nor there
Yeah.
in regard